WSPA Plus exclusive podcast where we talk to professionals here in the upstate about the what's what, their career, lifestyle, and what it takes to get to where they are today. Joining me today on the podcast, we have board-certified surgeon Dr. Jessica Gonzalez Hernandez with a subspecialty in bariatric and minimally invasive surgeries. Thank you so much for being here with us today on the podcast. How are you?
Good. How are you?
I'm
Thank
good.
you for inviting me.
Did you have a good holiday?
I did.
I appreciate you coming on. We're talking predominantly bariatric surgery. For those of us at home who maybe are unfamiliar with the terminology, what do you do?
Yeah, so I do, as a bariatric surgeon, I do weight loss surgery. So surgery to help patients lose weight. But then I also, as a general surgeon, I do hernia surgery, gallbladder surgery, and all other kinds of surgery.
So the reason and what sparked my interest, much of the general population, there is just so much conversation these days about GLPs and semaglutides. I'm pretty ignorant to the matter. Can you break down for people at home, are they the same thing? What is the craze with these new weight loss drugs that people are now using?
Multiple drugs that have come out over the last couple years for weight loss. There are GLP-1 and GIP agonist, receptor agonist medications. There's like the Wegovy, the Zepbound. Now the Wegovy came out in a pill recently. So, I mean, it sparked the interest of the patients because they work. Patients pretty much say that they take away the food noise that they constantly have. They now can feel actually what it feels to feel full. They can actually put away the plate and not eat at all. All those things that they couldn't do before when they were taking the medication.
Wow.
So it's caused a big change in patients. It's really helped them see changes when they're dieting, exercising, when before they weren't seeing any changes.
If I'm coming to you just to have the conversation, are you a last ditch effort? How does that work in terms of like, okay, I'm ready to get to this point where I'm ready to start my GLP-1s. I am not seeing change. Or am I coming to you for dietary advice? Do I need to know maybe what about my exercise regimen? How does that part of it work?
So we are a comprehensive weight loss program. So you come to us and we will talk with you about all the options, okay? Including from diet and exercise only to medication to surgery, okay? Because, I mean, there's patients for everything. You know, there's situations where surgery is best. There's situations where medication is an option. And there's patients that don't want to do medications, don't want to do surgery, and then diet and exercise are the only thing. But we have a dietitian in our office that also helps, you know, talks to the patients, help them make a plan. So we try to help, you know, our goal is to help patients live longer, have a better quality of life, and feel good and confident with themselves. So however that form may be, that will suit them, that's what we would help them.
When we hear all of these buzzwords, Ozempic, Zepbound, Mounjaro, Wegovy, can you talk to me about what are the differences between these injectables that people are using? Why would I go one way and not the other? How does that work? Which I understand is probably a conversation you would have with yourself. Sure. But for people at home who are just curious, what are the different products and what do they do?
Sure. So in terms of the GLP-1s and GIPs, so we have Ozempic and Mounjaro, Zepbound, and Wegovy. Okay. Those are kind of the biggest ones right now. Ozempic and Mounjaro are medications for diabetes. Okay, so strictly for patients with type 2 diabetes. Ozempic is semaglutide, which is the same as Wegovy. Okay, Wegovy is also semaglutide, but Wegovy is the version that is FDA approved for weight loss. And then we have Mounjaro, which is a GIP and GLP-1 receptor agonist, and that's tirzepatide, and it's the same thing as Zepbound, which is also tirzepatide, but Zepbound is the version for weight loss, is FDA approved for weight loss.
Oh, okay.
Versus Mounjaro is type 2 diabetes.
Because there was a while where people were talking about an Ozempic shortage for people who needed it due to diabetes. So then they were able to start a different, I guess, drug specifically for weight loss? That's how that came about?
Yeah, so the thing was that during that time, Wegovy was still not FDA approved for weight loss necessarily.
Okay.
So Ozempic was the only option, but the studies were going, and it was showing patients were losing weight. That was one of the side effects. So a lot of patients that had pre-diabetes, that had other comorbid conditions, were able to get on that medication for different reasons, and we're seeing the weight loss, and that's where the shortage came, because it was not being only used by the patients with type 2 diabetes, but the patients that had other comorbid conditions needing the medication for weight loss.
How are these drugs administered? Now there's a lot of conversation about oral supplements, but I understand some you do through a shot. Are there different methods? Are those two predominantly it? How does that work?
Yes, so the Ozempic, the Mounjaro, the Wegovy, and the Zepbound, they all come in injectable forms. There are weekly injections, okay? There's some GLP-1 agonists that have been out longer that are daily injections, but those are not as the weight loss is not as high as with these other ones. And now recently Wegovy, which is semaglutide, came out with their pill. There's now a daily pill that you can take for Wegovy for weight loss, and that was just recently FDA approved.
Are you seeing any of your patients take their weight loss drugs this way? Is that how they're going about it?
Yes, so both pills and injectables.
And is it effective?
Yes, I mean, I think with the right combination of, eating habits, activity, and the medication, we can see lots of changes in patients.
Okay. So in reading up on this, I understand that essentially when you start the product, you are administered a dosage. Is that correct?
Depending on which medication, you start at one dose, and every month we go up, because there's different dosages, and every month we go up to decrease side effects. Because you don't want to start at the highest dosage, because then you'll have higher side effects. You need to let the body kind of get used to what the medication does.
Wean into it a little bit, let the body adjust. What are some of those side effects that you might be hearing or noticing when they're talking about some of these weight loss drugs?
Sure. So what the medication does, pretty much, it mimics the hormones of the body, and what it slows down the gastric emptying. So one of the most common side effects will be nausea and vomiting.
Yeah.
Because if you are not feeling, or holding on eating and eating smaller portions, the stomach is not moving, the food is just sitting there, and then patients will be more prone to getting nauseous and vomiting. So the most common are either nausea, vomiting, diarrhea, or constipation, depending on the patient.
Well, I can absolutely see how that's an effective way to not want to eat if you're looking at your food and you're feeling kind of queasy. In terms of the dosages, what are some of the higher numbers look like? What would be the highest that it goes? Is this in milligrams? How does that even work?
Yeah, so for example, Ozempic and Wegovy, it goes from 0.5 milligrams to 2.4 milligrams is the highest. Ozempic goes to 2 milligrams, and the Wegovy goes from 0.25 to 2.4 milligrams. Then you have the Mounjaro and the Zepbound. Those go from 2.5 milligrams to 15 milligrams.
Oh, wow.
But they're just different molecules. Doesn't mean that 15 is higher than 2.4. It's just based on the medication is the dosage.
Right, the way that it is. Okay, and are you seeing more people stay at a certain, down the middle? Do they eventually get to that higher dose? Are there people who can stay on the lower doses? How does that work?
So the recommendation really for weight loss is to get up to the highest dose. The studies were done, most patients were on the highest dose, and they were there for about 56 weeks, and that's when they saw the weight loss for Wegovy was about 15.7%, and for the Mounjaro about 22.7%. But there's definitely some studies that have been done, especially on Zepbound, where patients were at 5, 10, and 15. Oh. So those are kind of the maintenance dosing that you can use, and depending on the patient and how much weight they have to lose, I have some patients that only have to get to the 5 milligram dose to lose the weight, and other patients that do have to get to the highest dose.
And what is that timeline? You just mentioned 56 weeks. If I'm just starting, I need to lose 100 pounds. It's not going to come off in a month. What is a realistic timeline for people when they come to you experiencing this they're living and being overweight, obese, and they want to start to see a change in their life. Is it a year? Is it longer? How does that work?
So it varies on the method. So medications, I usually tell them to expect 2 to 4 pounds a week. Okay.
Oh, wow.
Sometimes, 2 to 4 pounds a month.
Okay.
Usually it varies. With the medication, sometimes they'll lose more weight. I mean, I have patients that, for example, I saw today that they lost 15 pounds in a month, but that doesn't happen all the time. And at some point, that's going to slow down. The more weight you lose, the slower your metabolism gets, and the harder it will be to lose more weight. So on medication, I tell them to expect to lose about 15 to 22% of their weight in a year. So whatever the weight is. With surgery, certainly they can lose over 100 pounds in a year or less.
Is there a parameter of where a patient diet and exercise is probably the right fix for you? Is there a weight that you look at? Do you consider BMI when you start to talk about these GLPs and semaglutides? How does that work?
Yes, so BMI is very important. So obesity is you're overweight from a BMI of 25 to 30, and then over 30, you're considered to be obese.
Okay.
So medications are recommended for patients that have a BMI over 27 if they have one medical problem, like high blood pressure, diabetes, sleep apnea, or patients with BMI over 30 if they don't have any medical problems, okay? And then surgery is recommended for patients that have a BMI over 35 if they have one medical problem, like diabetes, high blood pressure, sleep apnea, or BMI over 40 if they have no medical problems.
Okay. In terms of these weight loss drugs, I can't imagine that this is a one-stop shop and this is how it is. You can't be taking these injectables and then going to eat processed food all the time. How important does lifestyle play a role in maintaining that goal weight and also hoping to keep it off? Like you mentioned, some patients experiencing either being able to do so or fighting gaining weight back.
Sure. So I think it's super important. The medication, I always say the medication and the surgery are just a tool that we're giving you to have time to make the changes that you need in your lifestyle habits so that this weight loss can be long-term. And in order to lose the weight and to keep it off, there's definitely changes that have to be made in the diet. We usually recommend that they do a high protein, low carb, low fat diet. And we try not to be strict. We want patients to be able to be exposed to everything and be able to pick the foods that they should eat and should not eat.
Right.
And physical activity, we recommend, the recommendation to lose weight is that you do about 300 minutes of moderate exercise every week. So we try to work with them to slowly, start 15 minutes a day and then add from there until, as the weight comes up, they're able to do more. And then most of the patients that are successful keeping the weight down is because they have adapted to these changes and they've continued the changes past the weight loss.
It is a lifestyle change. And ultimately, from what I understand, some of these medications can be pricier. So why would you waste your money if you're not committed to getting sleep, eating healthier, drinking more water? I want to move on to some of the stigmas just surrounding being on a GLP. What I've come to find just in my social life, I know a lot of people who are secretly on these GLPs, but they don't talk about it. It becomes evident when, your friend Jackie is all of a sudden stick skinny and you could blow away in the wind. But Jackie maybe just isn't comfortable with sharing it. And of course it's to each, their own. But I do think that there is a stigma and kind of a negative stigma around people taking them, using them. Are you seeing that in the patients that you're having these conversations with?
Yeah, I definitely see lots of patients that come and they're afraid of their family knowing what they're doing. Like that they tell me, I'm having surgery, but please don't tell my family member. They're here to make sure my surgery goes away, but they don't know what surgery I'm having. So please don't tell them what surgery I'm having. Just tell them that if everything went well, how everything went through the surgery.
A lot of pressure to put on
yes.
you, huh? Jeez.
Or they're on medication and they're like, my mom told me I cannot be on these medications, that
Right.
I should not take any of these, but I really want to take them. So like if I ever come here with her, please don't tell them what medication I'm taking.
Yeah.
Because they, they'll bring them with them in the office, and then I'm just speaking about XYZ, but not
In code,
yeah,
speaking in code.
pretty much. But I think the stigma comes from our culture, our, where we live, like in terms of obesity. Obesity has been a stigma for so long.
Right.
Because it's not, people don't, understand that obesity is a chronic disease. It's just like having, high blood pressure, sleep apnea. It's a disease that needs to be treated. And there's lots of patients that are obese, not that necessarily by choice. It could be genetic syndromes, it could be environmental issues, and things that, medical problems that don't allow them to lose weight. And I think once we fight the obesity stigma, then people will be a lot more open to talk about their story.
What is some of the misinformation you might be seeing or hearing in regards to the GLPs?
In regards to the GLPs, well, the patients come saying, this has a lot of side effects. I don't want to be on them because they have a lot of side effects. Yes, every medication has side effects, even the ones that you take for your blood pressure, your diabetes, etc. But the important thing, when you do it with a doctor, you're being monitored. Like, we are seeing these patients often. They are able to call our office if they have any issues. Other patients come and say, no, it will make me lose too much weight and I'll look like I am dead, a dead person walking. And I'm like, well, that's something that you can work along the way, because if you stay exercising, eat your protein, you can build muscle mass through your weight loss to prevent you, of you looking in the mirror and seeing that you've lost all this weight and you look different. But yes, after you lose weight, you're gonna look different. If you for 10, 15 years have been 150 pounds overweight, you're gonna look different when you lose the weight.
Absolutely.
And patients have to be okay with that. But I think the misconception, the most about these medications is side effects. Cost is a big thing. Patients
Sure.
Are afraid of the cost. They can't afford it, but they know they need it. And trying to find the way of being able to be on the medication. So I think the misconception is more about, I don't want to lose. They want to lose weight, but then they're like, I don't want to lose too much. Or I want to lose the weight, but I don't want to have the side effects.
Once I have gotten to the place where I want to be, we have been, through the trials and tribulations, I've been on it and I hit my goal weight. What's next? Then what happens?
Sure. So then, we work on maintenance, okay? And after you hit your goal weight, depending on what that may be, I tried for that to be at least with a 5 to 10 pound buffer, so that you're in a healthy weight range, but you have 5 to 10 pounds to fluctuate. And then once we reach that, there's no written protocol of what should be done. What I, in my experience, do, I try to wean down the medication as low as I can get it, where I see patients are maintaining. And I follow these patients. Once these patients have been on a medication, we see them either every 3 months or every 6 months, depending on how often they need to be seen. But we would start decreasing the medication and see if they're able to maintain the weight. If I see in 3-6 months they're able to maintain the weight, then we may start spacing it out. Instead of doing every week, maybe start doing every 2 weeks, and then every 3 weeks. But these patients should not get off the medication, unfortunately, because the patients that have gotten off the medication, I've just seen that they tend to regain the weight.
This sounds like the perfect opportunity for us to take a short, quick break. More Olivia on Purpose after this. Hello and welcome back to Olivia on Purpose, a WSPA Plus exclusive podcast. In the hot seat with us today, we have a board-certified surgeon, Dr. Jessica Gonzalez Hernandez, with a subspecialty in bariatric and minimally invasive surgeries. We appreciate you taking the time to chat with us today. We're essentially talking all things weight loss drugs and all that you've experienced as a surgeon with the patients that you have been seeing. I'm going to backtrack a little bit because I want to ask you about your career. How did you come into being a board certified surgeon? Why did you choose bariatric and minimally invasive surgeries? Was this something that was always a passion of yours? You fell into it? Talk to me.
Sure. So I guess I did my medical school in Puerto Rico. I come from a single mom. I have 3 sisters, 3 brothers, but I studied medical school in Puerto Rico, then met my husband there, the couples match. We ended up in Dallas, Texas. That's
Together?
Together, yes. He's a doctor too, and we were training together. Him on his specialty, and then I was doing my general surgery training. And then I finished my general surgery training. I always had I really like kids. At one point I thought I was going to be a pediatric surgeon, but then I really found a passion. I really wanted to build long-term relationships with my patients. I didn't want to be just the surgeon that you saw one time, had surgery, and then didn't see them again. And bariatric surgery caught my eye because I myself struggled with my weight for many years. And it was a way of helping myself by learning about it, but also helping other patients with this struggle that I had.
Mm-hmm.
And so I did actually 2 fellowships. I did a fellowship in pediatric minimally invasive surgery, where I learned to do very small operations in very small kids, babies and all. And then I did a year of bariatric surgery and minimally invasive surgery at UT Southwestern in Dallas. And that's where I guess all the passion flourished, and I really felt like that was my calling, and like I could help patients could come see me, and like I said, we leave the open door and they can always come back if they need help along the way. And it's a long-term relationship. I get, right now I have been able to see patients, after they lose the weight, some patients come to have weight loss surgery or lose weight with medications to be able to have kids because of not being able to get pregnant. So then I see them when they have the kids, and then they come with their kids. They're I've been doing now here in Greenville for 8 years, so I get to see their kids growing too. But I have families, wife and husband and wife that come, or mother and daughter. So it's great to build those relationships where patients keep coming, or they keep sending their family members, their friends, their church friends. Like it feels good to be able to help the community and help them live longer, have a better quality of life, feel more confident.
What brought you from the Texas area, from Dallas to here to the upstate? How did you make the move over here? Was it because there was an opportunity to practice, or?
So I actually moved here because my middle sister had moved here first, and she moved from Puerto Rico to Greenville, and she established here with her husband and had my first nephew here. So it was we wanted to be closer to family. She had already established here. We were in Dallas. Dallas had become a very big city, and we were ready for a change. We wanted something smaller where we could make a bigger impact in the community. And so we decided, I said, well, my sister moved to Greenville. What about we look at the hospitals there?
Load the truck up. Let's go.
Yes. And my husband found an interview. He got an interview that same week. And then we flew here. They did an in-person interview. And actually, I moved here without a job.
Oh, did you?
Yes.
Wow.
Because I was finishing. He was already working in Dallas as a gastroenterologist, so he found his job here. But I said, my sister is there. I'm sure I will find a job as a surgeon. And he accepted his job. Then through one of his partners, we found that his neighbor was a surgeon in another hospital, and that one of his colleagues was leaving, and that person was a bariatric surgeon.
Open the door for you.
So then I just called the recruiter and say, hey, I am moving to Greenville.
Yeah.
And I'm a bariatric surgeon, and I know you're losing one.
Yeah.
I'm
the gal.
I want the job.
I love that. What's that like, being in a powerhouse marriage? I mean, that's incredible. That's awesome.
Yes.
Are you on predominantly same shift type schedule, or are you alternating? How does that work?
It varies. I mean, for the most part, during the week, we work during the day. But when we're on call, it can be a little crazy.
I bet.
Finding who's going to take care of the kids.
I love it. So this is a just no-brainer. I'm going to ask you, we're going to shoot it off, and then you just answer what you feel is the perfect answer. You ready?
I'm ready.
Okay. And this is all, by the way, pertaining to, obviously, her subspecialty when it comes to being a surgeon. Scalpel or laser?
Scalpel.
Morning rounds or night calls?
Morning rounds.
Would you rather have one large, perfect incision or several small ones?
Several small ones.
I had to guess, but I just figured I would ask. If you had to pick one forever and ever, diet or exercise?
Exercise.
It's kind of a tough one because obviously I know that they're somewhat married, but if not a surgeon, which career path would you pursue?
I would have been an artist.
An artist? What, like painting, drawing?
Maybe, yeah, I love crafting
Okay.
and painting.
Do you have an artistic outlet now?
I do have a craft room in my house
I love that.
that I do a lot of different things
That's awesome.
when I have time.
Who is your favorite singer?
Taylor Swift.
T Swift. Specialty switch or stay put where you are?
Stay put.
Okay. Would you rather teach a trainee or would you rather mentor residents?
I mean, they're both the same.
Okay.
I think mentor residents.
Yeah. And what is more rewarding to you, the perfect outcome or a challenging case?
A challenging case.
I love that. Yeah, I can see the way that your brain is wired and the way you work. Well, Dr. Jessica Gonzalez Hernandez, we appreciate you coming on with us today and talking all things weight loss. If you have any questions for her, of course, I will have an email that's up for you on the screen now, as well as my social media handles, so you can follow along with Olivia on Purpose and shoot me any questions, or if you know a guest that you'd like to see featured on the podcast. That is all for today with Olivia on Purpose. Don't go anywhere. We'll be back next week with more WSPA Plus exclusive content. Thanks, guys.